So, a very good afternoon to all of us gathered here today, and a special thanks to Sir Professor Prabudh Goel, who's a professor from IAPS, New Delhi. So he's come and he's very graciously agreed to spend his time in teaching us about the basics as well as advanced aspect of Wilms tumor, so that we can get a better understanding of the subject. As I was just saying, this lecture is basically designed, I guess, by Sir to answer any questions that he would expect a postgraduate to have, and what our outlook should be on the topic. So over to Sir.
Thank you, Evangeline. Thank you, Elish. First of all, I want to congratulate you both as youngsters from IAPS on taking up this initiative. So, we need young leaders like you all to take the banner ahead. Very good evening to all of you who are there in this session, and greetings from the All India Institute of Medical Sciences, New Delhi. So, like I made mention just now, my intention here is not to teach you Wilms tumor in a way that you become expert in that, because nobody can teach Wilms tumor in an hour or so. My intention here is to make it look pretty simple for you. And the best way to utilize this lecture would be, don't try to make any notes. It is anyways being recorded. Just try to build up your knowledge base on whatever is already there in your mind, and take out some time on the weekend, maybe Sunday, and just read the standard textbooks. So once you listen to me today and you read the standard textbook, maybe tomorrow or day after, I think that would be the end of the story for Wilms tumor, or maybe the beginning of the story. Because I understand, and you also understand, that there is not a single postgraduate student in India at least, and probably globally, who can pass the MCH or the corresponding exam internationally without talking about Wilms tumor. I have appeared for MCH myself. I have witnessed so many exams, and now I'm an examiner myself. But I'm yet to see an exam where the topic of Wilms tumor did not figure up at all. It just doesn't happen. So why does it happen this way? Why is, Wilms tumor so unique? How is it different from other tumors that we deal in pediatric surgery? And how is it different from other tumors which fall outside the domain of pediatric surgery? I already see some messages. Is it
Sir,
slide?
sorry to disturb you, sir. Your slides are not visible, sir.
My slides are not visible.
No, sir.
So right now, only the bottom screen bar type of thing is visible right
Okay,
now.
I'll stop
It
sharing
was
and
visible.
I'll stop sharing. I'll reshare my slides. I thought all the while that I was visible. Share.
Yes, sir. Start.
Okay. So I'll let you see this was my first slide. This was the second one, just a general slide. I didn't mean to teach anything. And we're discussing that Wilms tumor is unique. Now, why I say Wilms tumor? My slides are visible now, no issues?
No
Yes, sir.
issues, sir. Can see very clearly.
Great. So, Wilms tumor stands as a remarkable success story in pediatric oncology. I request others to kindly mute their, because obviously, thank you. So Wilms tumor is a remarkable success story, not just in pediatric oncology, but if you have a global outlook on all the tumors, even then, the results that we have achieved in Wilms tumor are mesmerizing. So it's not just another solid tumor of childhood, but rather a paradigm that fundamentally shaped the modern approaches to cancer treatment in children. So why do I make this statement, and why I say that Wilms tumor is unique? So this is the first slide where I'm trying to tell you that Wilms tumor is unique. So unlike many adult cancers where the survival rates, they plateau at discouraging levels, Wilms tumor has exemplary results. We have achieved cure rates which exceed 90%. Now, this enormous success represents a hard work, the culmination of decades of carefully designed clinical trials. You all have heard about NWTS, SIOP, the international collaborations, and the recognition that childhood cancers require fundamentally different approaches as compared to adult malignancies. So the transformation of Wilms tumor from a uniformly fatal diagnosis. So in the early 20th century, when a child used to have Wilms tumor, it was considered to be fatal, uniformly fatal. And we started our journey from there. And today we have a condition which is highly curable and represent one of the medicine's most remarkable achievements. So this is the curve showing the success that we have achieved. Then second point, we are all aware that Wilms tumor is an embryological tumor. So that is what the embryological origin that accounts for the uniqueness of Wilms tumor. Unlike most adult cancers that arise from genetic mutations, and these genetic mutations are acquired by us during our lifetime over the decades, but Wilms tumor is a developmental aberration which occurs during nephrogenesis. So, if at all the genetic factors are responsible, these genetic factors have been acquired either from the mother or the father, or it's a mutation which happened before the child is formed. This tumor recapitulates the normal kidney development. You might have heard, we'll talk about later, that the histology shows classical three elements. You have the stromal component, the epithelial component. So that's why I say it recapitulates the normal kidney development. You have the blastomal, epithelial, and stromal elements. And these elements are mirroring the metanephric blastema's natural differentiation. Now, the developmental origin of Wilms tumor provides you unique insights both into normal organogenesis as well as into malignant transformation. Hence, when we talk about bioinformatics, genomics, and we're looking into how genes work, Wilms tumor is actually a model for understanding how the developmental pathways can contribute to producing malignancy. Then my third point here is the surgical oncology interface. So this is what I have tried to depict. I couldn't figure out a better way to show my point. But from a surgical perspective, Wilms tumor presents some unique challenges which differentiated from other pediatric solid tumors like hepatoblastoma or rhabdomyosarcoma of the bladder. So the kidney is retroperitoneal in location. We all know that. It is intimately related to major vascular structures, the renal artery, the renal vein, the aorta on the left side, the IVC on the right side, you have the gonadal vessels. And there's a potential for bilateral disease to create surgical scenarios which are rarely encountered with other pediatric malignancies. We are aware that there's a debate between NWTS or COG, what you call it now, as well as PSYOP, between upfront surgical resection versus preoperative chemotherapy. And now this thing has shaped the pediatric surgical oncology practices, and it still continues to influence our treatment protocols worldwide. So, we are now into the phase when we are discussing the umbrella protocol. So I'll come back to it. Then another unique feature is the genetic complexity and syndromic associations. I don't know how deep you people have gone into genomics, but as far as I have understood, perhaps there is no other pediatric solid tumor which demonstrates such diverse genetic underpinnings as you see in Wilms tumor. So the association of Wilms tumor with multiple genetic syndromes, complex chromosomal abnormalities, both germline as well as somatic, they create a complex genetic landscape. So I'll give an example. You don't need to memorize that, but we have conducted a study on 5 patients of Wilms tumor, only 5. We took the cancer tissue, we took the normal renal tissue, we did a whole genome sequencing, and we identified 68 new genetic markers which have not been reported in literature. So you see, we have a lot of tumor suppressor genes. We have now more information on developmental biology. We know about cancer predisposition syndromes. You might relate to your prior information when you think about WT1, which is located on the 11th chromosome. It's a tumor suppressor gene. And again, this provides crucial insights into transcription regulation during development and tumorigenesis. Then my next point on why Wilms tumor is unique is that it gives you a unique blend of international collaboration. See, the success in treating Wilms tumor largely resulted from unprecedented international collaboration, such as that exhibited by the NWTS, the National Wilms Tumor Study Group, which later became COG or the Children's Oncology Group. Then we have the PSYOP or the International Society of Pediatric Oncology. The collaborative efforts have demonstrated that pediatric cancer treatment could be standardized globally while accommodating regional differences in healthcare delivery and cultural practices. So, these protocols have provided global standardization and still accommodated regional variations. So, I hope by this point you have 5, 6 points to remember why Wilms tumor is unique. You will not go into the exact details. In case you want to revise the points, I'll just go back. So number one, the rise in the success rate from a uniformly fatal tumor to results more than 90%. The embryological origin of the tumor, which means it is not completely explained by the mutations in the mutations acquired during the lifetime of a patient. Then the unique surgical interface, the extensive genetic basis of this particular tumor, and the exemplary results put forward because of international collaborations. Now, with this, we go on briefly to the history of Wilms tumor. Again, I would suggest you all to just listen to this as if somebody is telling a story. And I'm sure you'll retain some 4, 5, 6 points, which are sufficient for you when you're speaking somewhere, when you're talking, so look knowledgeable. So we all know that the tumor is named after Max Wilms, who described this tumor in 1899. But little do we know that this tumor was first described in 1814 by Rance, R-A-N-C-E, Rance.
అంటారా
1814.
విను మరి
So this tumor was described in 1814 by Rance. Then in 1872, there was a description by Ebert, and in 1875 by Cohnheim. Yet it is named after Max Wilms because he published a monograph. So often I don't remember that name. It's a German word, but if you translate it into English, it means mixed tumors of the kidney. It was published in 1899, and it provided the first detailed pathological description and established the foundation for modern understanding of this malignancy. So Wilms, I'm talking of this guy Wilms, his original work was revolutionary because he recognized the embryological nature of the tumor. However, he commented that the tumor contains multiple tissue types. So he gave a concept of mixed tumor, which of course was not very accurate by today's standards. But then, of course, we have to agree that he provided the first systematic approach to understand this complex malignancy. Now, you know that Wilms tumor has become widely accepted. I'll tell you one more thing which is interesting, that earlier when you used to write Wilms tumor, that was very early when I was a resident. So there was a mix. Some people used to write Wilm apostrophe S because it was named after Wilms. But gradually we have phased off that apostrophe and we simply write now Wilms. So it's the name of the tumor now. Although it's also named by nephroblastoma or embryonal nephroma. So this is a brief about Rance, Ebert, and Cohnheim. And then this is okay. This is the name diamystis. There's no need to remember, but essentially it means mixed tumors of the kidney. Then came the chemotherapy era, pre-chemotherapy era, and the chemotherapy revolution. So during the first half of the 20th century, Wilms tumor remained a tumor with a fatal diagnosis. Survival rates were less than 20%. Treatment was surgical resection, that too when it was technically feasible. Surgical mortality itself was 25% because the tumor used to be large. There were technical challenges in surgery, and pediatric post-operative care understanding was limited. Now, I am not sure if you read about this name, but in Chicago, we have the Children's Memorial Hospital, and Dr. Willis Potts was working there. He emerged as a pioneer in pediatric surgical techniques for Wilms tumor. So he focused on two things. Number one, early vascular control. So whenever he would operate on a Wilms tumor, he would say take a vascular control. And then he had his systematic surgical approaches that reduced the operative mortality significantly and established principles that remain relevant even today. Then radiation therapy came somewhere around 1930s and 1940s, and that was the first multimodal approach to Wilms tumor treatment. So you might remember the name of James Ewings, who first recognized that Wilms tumor shows remarkable radiosensitivity. So he was James Ewing sarcoma. He was the first person to say that Wilms tumor has radiosensitivity. However, those techniques were crude, so they were effective, but they resulted in a lot of acute and late toxicity. Then came the chemotherapy revolution in 1950s to 60s. So if you want to just make up your mind here, so the radiotherapy came somewhere around 30s and 40s, and chemotherapy came in 50s and 60s. So the first drug which was discovered was actinomycin D or dactinomycin. And from there, we have never looked back. Then came the birth of these cooperative group trials, the NWTS and the SIOP. So NWTS, or the National Wilms Tumor Study, was established in 1969 under the leadership of Dr. Ngo. He was Gilo Ngo. He was the one who had established, given the foundation for modern multimodal therapy. So when you talk of multimodal therapy in Wilms tumor, two names come to our mind, Dr. Evans and Dr. Angio. So I'm talking of this Dr. Angio, who was the first person on this. He established the NWTS, which is a revolutionary approach to clinical research. Of course, NWTS standardized the treatment protocols across multiple institutions, and they addressed clinical questions in a systematic manner through a lot of randomized controlled trials. NWTS was launched in 1969. Yes, it was launched in 1969. The study randomized initially, the very first NWTS 1, it randomized patients to receive either postoperative radiation or no radiation therapy. We'll come into the details later. This was just to give you an idea of how the treatment of Wilms tumor has evolved. Now, while the North American investigators were pursuing the NWTS approach, the European investigators almost simultaneously developed an alternative strategy, what we call as the SIOP, SIOP, Society International Oncology Pediatric, that's the actual form. So the SIOP approach was pioneered by investigators like, I remember one Limerle, other was Oberlin. And I don't think you need to remember this approach. But yes, you need to know there are two major philosophies. And then, the philosophical divergence created two major paradigms that even persist today. Now, NWTS is now what you call as the COG group, Children's Oncology Group. It maintains that upfront surgical resection provides optimum outcome because it allows for precise risk stratification. On the other hand, SIOP approach argues that preoperative chemotherapy reduces tumor burden, facilitates surgical resection, and minimizes the risk of tumor rupture and local recurrence. So this is the main philosophical difference between NWTS and SIOP, or COG and SIOP. And I'm sure this you'll supposed to there'll be some point in your MCH exam where you have to make this statement. Now, if you would have dwelt into the details, you would realize that both the approaches have excellent outcomes, nearly 90% in favorable histology cases. So that means that for the same disease, there are multiple treatment strategies which could be equally effective, just that they are applied systematically. Then we come to this histopathological grading and risk stratification. So that's another very peculiar aspect of Wilms tumor. See, the evolution of the pathology of Wilms tumor has paralleled the advances in treatment. So just as we are getting better with the treatment, we're also getting better with our understanding of pathology. Dr. Beckwith and Palmer, the two names which come to our mind when we remember the publication which happened in 1970, they pioneered the pathological classification of Wilms tumor into favorable and unfavorable histologies. I know all of you know about favorable histology Wilms tumor and unfavorable histology Wilms tumor. This work provided the foundation for risk-adapted therapy, allowing the clinicians to intensify treatment for high-risk patients while saving the better prognosis patient from the wrath of chemotherapy and radiotherapy. Furthermore, it was recognized that all renal tumors are not Wilms tumors. So we had a clear cell sarcoma of the kidney, we had a rhabdoid tumor. This happened in 1980s. And again, we have not looked back from there. Then this is another interesting aspect, the beginning of the molecular era. So WT1 gene, which is located on chromosome 11, was identified and characterized in 1990 by Constantini and his team, and that marked the beginning of the molecular area in Wilms tumor. Now, what you're supposed to know is WT1 gene is a very important gene. It's on 11p13. It is a tumor suppressor gene. So we know that it has an important role in Wilms tumorigenesis. It has established the foundation for understanding the complex genetic landscape of this malignancy. Then the other gene which you all might be aware is a WT2 gene. So now, for your memory, WT1 is located on 11th chromosome, and so is the WT2 gene. The exact coordinates for WT1 are 11p13 and for WT2 are 11p15. So you can, it's easy to memorize this thing here. So this is again a summary of how we have, improved from a less than 20% survival to more than 90% survival, and all that we discussed so far. So now coming to those aspects of Wilms tumor which are very important to you when you appear for your exams. So Wilms tumor is the most common primary renal malignancy in children. It accounts for 6% of all childhood cancers, or you can say 8.1 cases per million children under the age of 15 years. There's a higher incidence in Africans and African American populations. We all know that the peak incidence of Wilms tumor occurs between the age of 2 to 5 years. 90% of the cases are diagnosed before the age of 10 years, and there is a rare case, rarely it is diagnosed beyond 15 years of age. Bilateral disease tends to present earlier as compared to unilateral disease. The median age for patients who have unilateral Wilms tumor is 3.5 years. The slight preponderance. So if you have 10 cases who are boys, then you'll have 11 females. So the ratio is 1.1 is to 1 and 1.1 is females. I have a question in the chat box. Okay, nothing. That's fine. Genetic basis of Wilms tumor. So we're talking of the WT1 gene located on 11p13. WT2 is 11p15. WT1 is a tumor suppressor gene. It's a zinc finger transcription factor. This gene is responsible for normal kidney and gonadal development. So trust me, you just need to memorize these 4 points. One point is it is on 11p13. Second, which is missing here, it's a tumor suppressor gene. Third, it's a zinc finger transcription factor. And fourth, normally this gene accounts for the normal kidney and gonadal development. Now, there are syndromes which are associated with mutation of the WT1 gene. First is the WAGR syndrome. Easy to remember because we have 4 conditions associated, each starting with this acronym WAGR. W is Wilms tumor, A is aniridia, G is genitourinary abnormalities, and R is retardation of growth. So in WAGR syndrome, the chances of the child developing Wilms tumor are more than 50%. Other syndrome associated is the Danish-Drash syndrome. So again, we have a triad of Wilms tumor, progressive nephropathy, which leads to renal failure. So see, that is important. Okay. And male pseudohermaphrodite. So Wilms tumor, progressive nephropathy, and male pseudohermaphrodite. Now, what is the significance of progressive nephropathy here? That if you know that your child has a Danish-Drash syndrome, you would rather focus on renal sparing surgeries or renal sparing modalities of treatment. Now, the inheritance is autosomal recessive, but that's a dominant negative WT1 mutation. Then the other syndrome is the Frazier syndrome, wherein you find gonadal dysgenesis, progressive nephropathy again, and gonadotropin independent sexual precocity. So these children have early puberty, sexual precocity, but when you check for the hormones, the gonadotropin levels are normal. The risk of Wilms tumor in Frazier syndrome is lower than you find in Danish-Drash syndrome. Now, from here, we move on to WT2 gene. There are other syndromes associated with WT1. Based upon your interest, you can go back. It's a good idea to have a table which you in your notebook, which you can revise frequently because, every syndrome has some features and you have to remember at least the basic features. So when you talk about WT2 gene, the first syndrome that comes to your mind is the Beckwith-Wiedemann syndrome, what you call as the hemihypertrophy syndrome. So you find macroglossia when the tongue is large. You find organomegaly, where the organs like liver and spleen have undergone hepatomegaly, splenomegaly. You find hemihypertrophy. And Beckwith-Wiedemann syndrome predisposes to embryonal tumors. Wilms tumor is one of them. The risk of Wilms tumor in Beckwith-Wiedemann syndrome is 7.5%. Now, there are 4 other genes, which you should be aware. So one is the WTX gene. This is located on the X chromosome. So WT gene on the X chromosome, that's the way to remember. So WTX gene. Mutations of WTX have been reported in literature in 30% of the patients. But I want to tell you again that we recently analyzed the data of 58% patient belonging to the Indian cohort, and we did not find 30% prevalence of WTX. So in this cohort of 58, I think there were 3 patients only. So probably this gene is not that prevalent in India, or at least in the cohort that I examined. So I'm not sure how many of you are aware, but I do a lot of bioinformatic analysis. I do computational biology. So for all the malignancies and congenital malformations, I would do a whole exome sequencing, which is a part of my research projects, and look into the genetic markers of the disease. And for those of you who might be interested or who might be wondering what it is, this is a very, very interesting field. So recently we analyzed, I'm just taking a little break here so that you all get time for information to settle down. But we analyzed some 115 patients of hypospadias. And we realized that this classification into distal penile, mid penile, and proximal penile is actually nonsense. Because when you look at the complications, there is an altogether different basis. So we found an altogether different basis to predict, and we'll be publishing the new classification system. But based on the genetics of these patients, we have found an excellent correlation with the outcomes कि किस patient में fistula बनेगा नहीं बनेगा. Coming back from to Wilms tumor, so WTX is located in the X chromosome. Then you have the CTNNB1 gene. I'm sure you must have read this gene in context of another tumor. Can you recall? Does hepatoblastoma come to your mind? Yes. So this gene pertains to the beta-catenin pathway, and if there are mutations in Wilms tumor now, it is associated with a favorable prognosis. Then mutations of the TP53 gene are associated with anaplastic histology and poor prognosis. Now, these days we have mutations in the microRNA processing genes like the DROSHA and the DGCR8. So again, what I have witnessed is that these days, many times you'll have a short note in your MCH written exams, which says write a short note on the genetic basis of Wilms tumor. So you need to talk about genetic basis in general. You can talk about WT1 and WT2 in detail. Make a mention of WTX, CTNNB1, TP53. This is something very new. If you can mention that counts as a recent advance, the microRNA processing genes, DROSHA and DGCR8. Then you can mention about the higher prevalence of Wilms tumor, higher prevalence of Wilms tumor when higher prevalence of genetic association when the Wilms tumor is bilateral, when the Wilms tumor is familial, and when the Wilms tumor associated with some syndrome. So 3 conditions. The genetic basis is higher when the Wilms tumor is bilateral, number 1. Number 2, when it runs in the family. And number 3, when it is associated with some syndromes. So familial Wilms tumor, which is encountered in less than 2% of the cases, inheritance is autosomal dominant with incomplete penetrance. So for those of you who are wondering what is incomplete penetrance, so if you remember the Mendelian inheritance, so you know what is autosomal dominant. But when all the patient would not present with the trait despite having an autosomally dominant inherited gene, that is called as incomplete penetrance. Now, what happens in familial Wilms tumor? These kids are diagnosed early, number 1. They have a higher incidence. Somebody has written in the chat box, can you get the paper of hypo? It's yet to be published. Yes, you'll all have it, don't worry. So there's an earlier age of diagnosis for familial Wilms tumor. There is a higher incidence of bilateral disease, increased frequency of associated anomalies, and multiple family members affected across generations. And of course, you can add that you have a higher chances of finding a genetic basis for this disease. Now, when we come to the pathology of Wilms tumor, you might get a short note on writing the pathology of Wilms tumor. You might need to discuss this when you're presenting a long case. So you see, pathology as of now is one of the most important prognostic factors. And if I try to oversimplify the context, then there are 2 major categories: unfavorable histology and favorable histology. And as destiny would want, we have 90% cases of unfavorable histology, and there are 10% who have favorable histology Wilms tumor. Now, it's an embryological tumor, the normal embryogenesis which went wrong somewhere. So when you look into histology, you find there's a classical triphasic pattern. You have the blastomal component, the epithelial component, and the stromal component. Now, blastomal component is comprised of small undifferentiated cells, which have a high nuclear to cytoplasmic ratio. This is the term which the examiners want to hear, that the blastomal cells have a high nuclear to cytoplasmic ratio, and it represents the primitive metanephric mesenchyme. That is true for all three. Epithelial component is the tubular and glomeruloid structures of the metanephric blastema, recapitulating normal nephrogenesis. And the stromal component corresponds to the stroma. So these elements may include smooth muscle, skeletal muscle, cartilage, bone, or fat. Now, having said that you have these three components, when would you say that this tumor has a triphasic pattern? Obviously, when you have all the three components. When would you say that it is epithelial predominant? So when the epithelial component is more than 65%. So for that matter, any component of these three is more than 65%, you would say it is that particular component predominant. So it could be epithelial predominant, it could be stromal predominant, or it could be blastemal predominant. Now, suppose you have a component which is 55%, you would say it is a mixed variety, because unless a single component is 65, you would not say that to be predominant. Now, you might remember I talked about blastema when I said that the examiners might want to hear this line about the high nuclear to cytoplasmic ratio. So because of this, you see, we are here. Blastemal predominant tumors may have a slightly worse prognosis, particularly in the setting of stage 3 disease. And that is why when your histopathologist says that it's a blastema predominant tumor, a lot of us want to intensify the treatment protocol so that the outcomes are better. See, I've not filled my slides a lot. I have not tried to push in a lot of material. I have just put in the points which are very relevant and very important for you all. So when you talk of unfavorable histology, what are the features? Number one is presence of anaplasia, because of which this tumor will be resistant to chemotherapy, which will translate into poor prognosis. So 3 points. Number one, there is a lot of anaplasia. What does anaplasia mean? So you will see nuclear enlargement at least 3 times normal. You will see hyperchromasia, and you will see atypical mitotic figures. So this is anaplasia. Because of anaplasia, there is resistance to chemotherapy. And because of this resistance, these patients have a poor prognosis. This was about unfavorable histology. Now, this anaplasia could be focal. This anaplasia could be diffuse. So, as the name would suggest, focal anaplasia means that the anaplasia is restricted to one or few discrete foci within the primary tumor. On the other hand, diffuse anaplasia is present throughout the tumor or found in extrarenal sites. It carries a significantly worse prognosis and therefore intensification of the treatment protocols. Now we talk about the novel biomarkers, the biomarkers which have come into light somewhere in the past 1 decade. So one is loss of heterozygosity, LOH, loss of heterozygosity of 1P, which is found in 20% of the tumors. It is associated with a bad prognosis. Loss of heterozygosity at 16Q, which means it is present in 20-25% of the cases. It's again associated with poor prognosis. Now imagine if somebody has both these features, LOH1P and LOH16Q, then obviously it is the highest risk patient within the favorable histology group. So if the child has a favorable histology, but it still has 1P LOH and 16Q LOH, then within that group, these patients have the worst prognosis. We just talked about genes which are linked to microRNA, the DROSHA and the other genes. So these are the microRNA signatures. And now, telomerase has been known for long, but recently there's an ongoing buzz and people have discovered new findings regarding the increased telomerase activity, which is associated with advanced stage and poor prognosis. So I think for your MCS level, if you just remember these two terms and the name of the two genes, that should be enough. You don't need to go into further details of telomerase. Okay, so this part of Wilms tumor was a little technically difficult, but from here things ease out because we are all surgeons. Clinical presentation, common sense, abdominal mass, 80%. You all remember the photograph intraoperative Wilms tumor, so you know that the tumor is smooth, firm in consistency, and well-defined. These patients can have abdominal pain, which is mild and intermittent, sometimes non-specific, sometimes related to constipation rather than tumor per se. Hematuria can be there, but it could be microscopic or gross in 25%. 1 in 4 patient does have hypertension, which is because of excessive renal secretion or renal artery compression by the growing tumor. Finally, fever can be there, which is usually low grade and intermittent. What are the less common presentations? Acute abdomen. Sometimes the tumor undergoes a rupture or there is an intratumoral hemorrhage, sudden increase in size of the tumor, stretching of the renal capsule, and severe pain in the abdomen. These patients can have hypercalcemia, which is rare, but it does happen, especially when there is extensive metastasis to the skeletal system. Congestive heart failure is obvious possibility in any tumor which takes up a lot of blood supply. Then moreover, these patients do develop anemia and hypertension. So see, the tumor is taking away significant blood portion, increasing the load on the heart, plus the child has anemia and the child may have hypertension. So all these culminate into congestive heart failure. Finally, if there are pulmonary metastases and they are extensive, so somebody can have respiratory symptom. But yes, these four things are rare. So I have seen congestive heart failure. I have read about hypercalcemia. It was there in one of the patients in the ward, not directly under me. Acute abdomen because of tumor rupture and hemorrhage is still more common as compared to the other three. Physical examination. So, like a typical mass abdomen is examined, you have to be sure with all the findings. But yes, I would still try to make a mention that once you know that the child has a renal mass, palpation should be minimal. हमारे वार्ड में क्या होता है ना, पता चला मास एडमिट हुआ है, all the residents want to palpate that. Sometimes that may precipitate tumor rupture or tumor bleed. When you Usually in pediatric surgery, we tend to forget taking the blood pressure of our patients because you have a child of hypospadias, you have a child of hernia, UDT, you never mention the blood pressure. Even the anesthetist would not ask in a PAC. But remember, when there is a child of renal mass, please measure the blood pressure. It is high in 25% of the cases. Then look for associated anomalies like aniridia, hemihypertrophy, and genitourinary anomalies like hypospadias, undescended testes. So I'll tell you two interesting things. Glandular hypospadias is something I have seen. I can often remember 5 to 6 cases of Wilms tumor who had glandular hypospadias. I remember only one who had a proximal variety. I still, okay, that will make things more complicated. So I'll just skip this part, what I was trying to say. I still remember a case which was being operated by Professor Gupta, Professor D.K. Gupta. And this was a child who was being operated for an intra-abdominal mass for suspected Wilms tumor. But this tumor had not responded to chemotherapy. In fact, sometimes what happens is the mass does not shrink, but then it becomes necrotic and you can see it on CT scan. This mass even didn't become necrotic. And intraoperatively, he found that it was not the kidney. The kidney was actually absent in that child on that side. It was an undescended testes. So always examine for genitalia. As a pediatric surgeon, there are two things which you can never miss. Whatever be the diagnosis, forget about Wilms tumor for this moment. Whatever be the diagnosis, as a pediatric surgeon, if you're examining a child, you should not miss an undescended testes in a boy. And as a pediatric surgeon, if you're doing a laparoscopy or a laparotomy, you should not miss a malrotation. That's a crime, actually a crime. So coming back to the topic, abdominal examination, I said that palpation should be minimized once the mass is identified. Measuring the blood pressure is essential when you have a renal mass. When you're presenting an exam, make sure you talk about aniridia, hemihypertrophy, and genitourinary anomalies. Even if they are not there, they form a significant part of your negative history. And lymph nodes have to be examined, although you'll very rarely say that I found palpable lymph nodes. Imaging, ultrasound, CT, MRI, CT chest, and laboratory studies. We'll talk about them one by one. So that's all the obvious, most important first investigation, ultrasound of the KUB region or ultrasound of the abdomen. Whenever you are giving your exam or you're writing, the written exam or the viva, you need to tell why I need to get an ultrasound, or the examiner may ask, what will an ultrasound tell? Or he may ask, okay, I'm the radiologist, keep asking me questions and I'll keep giving you the answers. So you should know what questions to address to your radiologist. So number one, confirm the organ of origin. Is it a renal mass? What is the relationship to the kidney? It's upper polar, higher, lower polar. Is the other kidney also involved? Is this mass extending into the renal vein and the inferior vena cava? If yes, what is the proximal extent? Is it going into the suprahepatic IVC or is it intrahepatic? And ultrasound can actually guide you as to what should be your next investigation. So we know we have the option of CT and MRI. CT gives you the advantage, it can be conducted rapidly. So the child lies still for a few seconds, you have a CT scan. While an MRI would take time, sedation, or general anesthesia. CT is excellent for detecting calcifications, while MRI comes with the advantage of no radiation exposure. Now, what do you see? Can see the size and location of the tumor within the kidney. You can confirm or ascertain or qualify better the relationship of the mass to the renal vessels and the collecting system. You can comment on the extension of the mass beyond the renal capsule. You can comment on the involvement of adjacent organs. You can comment on lymph node enlargement. You can comment on the inferior vena cava or renal vein involvement. And you can comment on the appearance of the contralateral kidney on CT and MRI both. You should do a CT scan chest. So when we have a patient of Wilms tumor, we advise CT chest and abdomen. Why? Because we want to look for the chest metastasis. When you're doing a laboratory workup, you need to look for anemia, for thrombocytosis. You need to look into the renal function tests, including the electrolytes, and you need to assess the urine at least for microscopic hematuria. And I'm sure you all know why for all these findings. Now, there's a rare thing. Sometimes when you have a doubt that this could be neuroblastoma, then urinary catecholamines would help. Lactate dehydrogenase is a non-specific tumor marker. We usually don't do it. And sometimes you have a doubt about germ cell tumor. So alpha fetoprotein and beta HCG are helpful. Finally, tissue diagnosis. Do we need a biopsy? Don't we need a biopsy? How to go about it? So, this is a fundamental philosophical difference between the major cooperative groups, between basically COG and SIOP. We'll come to that. So COG says that the best way to approach a Wilms tumor is primary surgical resection without the need for a preoperative biopsy. They say that the tissue diagnosis can be obtained later at the time of nephrectomy. So a renal mass at this age should be taken as a Wilms tumor unless proved otherwise. Go ahead with a primary surgical resection, and the histopathology that you do will give you a tissue diagnosis. It will give you exact and complete staging information at time of diagnosis. Since you're not doing a needle biopsy, so there is no seeding of the needle tract with the tumors. Otherwise, what happens is whenever you do a biopsy, you are upstaging stage 1 and 2 to stage 3. So COG prevents that. But sometimes there's a potential for unnecessary surgery when it turns out to be a benign lesion. Then you feel that maybe if I had done a biopsy. But that's very rare. And these days with CT and ultrasound, you have a very good differentiation of benign lesions. SIOP, on the other hand, says that we'll give preoperative chemotherapy based on imaging characteristics to all these cases. So once we'll give chemotherapy, then we'll operate. So sometimes when you have a doubt, you need to do a tissue diagnosis before starting treatment, which means a needle tract biopsy, which means upstaging the tumor to stage 3, which means seeding of the needle tract with cancer cells. So what are the advantages of SIOP approach? It will result in tumor shrinkage. Your surgery becomes easier. Disadvantages, you will stage the patient exactly or precisely only when you do the surgery later on. So there's a possibility that you may overtreat the patient. Now coming to staging and risk stratification. So I've again, you'll find the staging in Chilaris King as a single table. I have tried to make it a little more elaborate because that will help you understand the special situations. And at the same time, you'll have an idea about what are the, easy learning. So what is stage 1? In a single line, it's a tumor limited to the kidney, which has been completely excised. Tumor limited to the kidney, which has been completely excised. Now, what are the special situations? Number 1, the renal capsule has to be intact. Tumor rupture should not be there either before surgery or during surgery. So it has to be excised in toto. Once excision has been done, there should be no residual tumor apparent beyond the margins of excision. The renal sinus vessels should not be involved. The interrenal vessels may be involved, that is not a problem. Stage 2, again, the tumor extends beyond the kidney. So stage 1 was limited to the kidney. In stage 2, it extends beyond the kidney but has been completely excised. So there we said that intrarenal vessels may be involved, but renal sinus vessels should not be involved. This was stage 1. In stage 2, we are accepting penetration of the renal capsule. We are accepting invasion of the renal sinus. We are accepting involvement of blood vessels outside the renal sinus. But once the surgery is done, there should be no residual tumor at or beyond the margins of resection. So, of course, that means that there should be no lymph node involvement also. Because if there is lymph node involvement, it goes beyond stage 2. So we come to the stage 3, which says that there is residual non-hematogenous tumor confined to the abdomen. It is a tumor which is remaining after surgery, and this has come from non-hematogenous route, and it is confined to the abdomen because the moment it crosses the abdomen, it becomes stage 4. So now what are the conditions that define stage 3? See, we are accepting lymph node involvements in the renal hilar region, para-aortic region, and paracaval region. That is why these 3 stations are sampled. In all, we have a 5-station sampling or 7-station sampling during nephroureterectomy. These 3 are part of that. Number 2, if there is diffuse peritoneal contamination by tumor. So you're operating, somehow your assistant pokes his finger inside the tumor and there is diffuse peritoneal contamination. If you see tumor implants on the peritoneal surface, if your pathology report says that there is gross or microscopic tumor at the margins of resection, or if your post-operative CT says that you can see gross tumor inside the abdomen. And finally, if the tumor is not completely resectable because of infiltration and you either do nothing or you do a debulking surgery. Now, if there is a tumor in the renal vein which was not detected preoperatively, but the pathologist tells you, then you should ask if there is a tumor thrombus at the resection margin. And if there is at the resection margin, if there is a tumor thrombus, if it is not there at the margin, if it has been included in the resected specimen and the margin is free, then it doesn't count as stage 3. Now, stage 4, hematogenous metastasis, metastasis by blood. Most common site, you all know it is lungs. 85% of stage 4 cases have lung metastasis, but can be there in the liver, in the bone, and in the brain. So you might remember I talked when I was talking of bone that it causes hypercalcemia. And of course, if the lymph node also the abdomen are positive for Wilms tumor, that is again counted as stage 4. Now, coming to stage 5 says there is bilateral renal involvement at diagnosis. So, stage 5 is actually something, so staging is 1 to 4. To make it complete, it is stage 5, which says there is bilateral renal involvement. But when you find a tumor at stage 5, you have to stage each kidney separately and manage accordingly. And now your treatment focuses on bilateral disease management, which means that modalities which can be used to preserve the renal parenchyma. You cannot do bilateral nephrectomy in this patient. Now, this was the COG classification. Coming to the risk stratification for Wilms tumor. So, COG stratifies these tumors into, if there is, it will come into stage 4. Okay, there's a question, IVC tumor thrombus in the supradiaphragmatic IVC. Supradiaphragmatic is stage 4. I have actually made a mention later in this. So COG stratification for Wilms tumor, it can be stratified into low risk, standard risk, intermediate risk, and high risk. So we know the tumor staging. This is just for brevity here, but now there are 3 parameters which are used to stratify tumors into risk groups. Tumor staging is one parameter. Second parameter is the histology, if it is favorable or unfavorable. And the third parameter are the molecular markers like loss of heterozygosity. So I remind you again, risk stratification into 4 categories: low risk, standard risk, intermediate risk, and high risk, based on 3 parameters. Number 1, tumor stage. Number 2, tumor histology. Number 3, molecular markers. So these are the risks. These are 4 risks, and then you have a very low risk group now. So when you have a stage 1 febrile histology tumor, which is less than 550 grams, age of child is less than 2 years, and there is no loss of heterozygosity, you say it's a very low risk, and these days we only do surgery, no chemotherapy. When it is stage 1 to 2 febrile histology with no loss of heterozygosity, it is low risk, and that is managed by a EE4A regime. We'll talk about these regimes later. Standard risk is stage 1 and 2 favorable histology with loss of heterozygosity. So stage 1 and 2, if it is favorable histology, no loss of heterozygosity, that is low risk. Stage 1 and 2 favorable histology with loss of heterozygosity, it is standard risk. And if it is unfavorable histology, stage 1 and 2 or any stage, it is high risk. Stage 3, favorable histology, no loss of heterozygosity, standard risk. With loss of heterozygosity, high risk. Bilateral Wilms tumor is stage 5. You have to individualize the risk stratification per kidney. Now, coming to the SIOP staging. So in SIOP, we are giving, we are applying, SIOP is applied after preoperative chemotherapy. So patient comes to you, you give 4 to 6 weeks of preoperative chemotherapy, you assess the treatment response and the residual burden disease. So now what happens is there is stage migration. So as there's a possibility that a patient was staged at stage 3 or 4 if he had been subjected to upfront nephrectomy. But now, since he was managed as per SIOP and he has been given chemotherapy already, you may end up labeling the patient as stage 2 disease. So now, when you are actually done the nephrectomy and you're doing a histopathological evaluation, it requires a careful correlation with the pre-treatment staging that becomes important because of this factor. Now, this is the SIOP staging system. I'll skip over this part because I don't know how different systems work, but in India, we are largely following the COG system of upfront nephrectomy unless the tumor is not resectable. Then only we all give neoadjuvant chemotherapy. So this is about stage 1 and 2 of SIOP. This is the stage 3, 4, and 5 of SIOP. 5 is the same. 4 is again distant metastasis. More or less, you will find they are the same. What changes is the grading. So here we divide into low risk, intermediate risk, and high risk. So when you find that more than 90% of the tumor is necrotic or there are no viable tumor cells, you say it's a low risk tumor. You say it's an intermediate risk when it's a mixed type Wilms tumor with no high risk features. So first we should know what is high risk. High risk is blastema predominant, more than 65%, diffuse anaplasia, or other histologies like rhabdoid tumor and clear cell sarcoma. And if it is not high risk and if it's a mixed type Wilms tumor, you call it as a low risk. I'll give an example on the right side. I think it's for you as a resident, it's good if you can memorize the risk grouping for both NWTS and SIOP. Management of Wilms tumor. So see, many times you'll get a question, and I have seen that most of the residents would straight away jump on to writing how to investigate and how to treat. Now, this is one additional point which you can add, which creates a very nice impression on the examiner. Doesn't need memorizing or doing a lot of work. See, you can simply say that the Wilms tumor management, in fact, for that matter, any tumor, is a multidisciplinary team effort. So where you have a pediatric oncologist who's giving the chemotherapy, you have a pediatric surgeon who's doing the surgery. You have a radiation oncologist who will do the radiotherapy part. You need a nutritionist who will take care of the nutritional needs of the child. And you have a psychologist who is there to address the psychological requirement of not just the child, but the parents, the family, and so on. So you see, this one point makes your answer look more mature, and automatically the person who's going to give you 60% has to make it 75%. Now, if you talk about COG, it favors immediate surgery. If you talk of SIOP, it talks about preoperative chemotherapy. But, both the groups recommend primary nephrectomy in children under 6 months of age. Now, these are the principles of surgery. In view of time, we can actually cut it short because I'm sure you're all surgeons and you know how to address these principles. As a surgeon, you have to ensure complete tumor excision without spillage. That is the most important point. You need to do adequate lymph node sampling for staging. Trust me, the most important reason for upstaging a Wilms tumor is lymph node sampling. So if you miss out on lymph node sampling, you may end up under-treating your patients and your results may be poorer as compared to those quoted in literature. Now, this is a history of NWTS protocol. So what happens is when your Viva is going good, then your examiner may venture into how many NWTS trials were there and what was the key findings of each trial. So if you reach this stage, then probably you have covered a good part of your long case Viva. What happens is that most of your examiners are senior people and they belong to that era when NWTS was actually being conducted. See, you look at NWTS 3, it comes from 1979 to 86. 4 covers 86 to 94 and 5 covers 95 to 02. So a very senior examiner would have been involved with NWTS 3, 4 and 5. He remembers things by heart and it's easy for him to ask. If you keep a copy of this, it's easy to remember. One is about combination therapy, two is about radiation therapy, three is about doxorubicin, four was pulse intensive, and five, of course, is molecular era. And then we have the umbrella protocol we'll be discussing. In short, you see that with every NWTS, the survival has increased 30%, 60%, 80%, 87, and 92%. Now, to make it simple, I have summarized. You can actually take a screenshot of this, or we are already recording. So this is the basic findings of each of the NWTs. You should have a basic idea. You will not go into the exact details. I'll try to summarize this NWTs here. So the key findings. Number one, routine postoperative radiation therapy is not necessary for children with stage 1 tumors or stage 2 tumors with favorable histology when post-nephrectomy combination chemotherapy consisting of VCR and ACD is administered. So VCR is vincristine, ACD is dactynomycin. When it's a stage 1 2 tumor who has favorable histology and you're giving this chemotherapy, then you don't need to give routine post-operative radiotherapy to these kids. Second point, the prognosis for patient with stage 3 favorable histology is better when you treat either with actinomycin D, vincristine, doxorubicin, and 10.8 gray of radiation. Alternatively, you can skip one drug, so you can give only actinomycin D and vincristine, avoid doxorubicin, but the radiation needs to be increased from 10.8 to 20 gray. Third point, whole abdominal radiation is indicated when there is extensive intraperitoneal disease or extensive intraperitoneal spill to take care of gross residual disease. Next point, addition of cyclophosphamide at the protocol dose to this combination of VCR, ACD and doxorubicin will not improve the prognosis for stage 4 favorable histology. Therefore, there is no need to give cyclophosphamide to stage 4 favorable histology. Then a single dose of actinomycin D, a single dose of actinomycin D is equivalent to divided dose courses. It results in the same rate of event-free survival, achieves greater dose intensity, and is associated with less toxicity and expense. So why not give it as a single dose rather than breaking it and leading to higher toxicity? Sorry. NWTS 4, 18 weeks of therapy is adequate for patients with stage 1 and 2 favorable histology. But when it is 3 and 4, you need to extend the chemotherapy to 6 months. Earlier it was 15 months. Now they say 6 months is good. Now, NWTS 5 said that gain of 1Q is associated with inferior survival in patients with unilateral favorable histology Wilms tumor. So 1Q gain has a negative impact on the outcomes. 1Q gain is the single most important predictor of outcome. And in the presence of 1Q, it supersedes. So it doesn't matter whether 1P or 16Q loss of heterozygosity is there or not. If 1Q is there, then the results are dominated by the effect of 1Q. In the absence of 1Q gain in unilateral field histology, these markers, loss of heterozygosity at 1P or 16Q, still retain their importance. Okay, then coming again to a simpler part, how do you manage tumor? So you know that we all do simple nephroureterectomy. At the All India Institute of Medical Sciences, New Delhi, once we reach the kidney, we'll actually open the Gerota's fascia, slip our finger inside the Gerota's, and just take it all around the kidney, and the entire kidney is out. You just have to tie the hilum. And we have proven that this has equally good results. Otherwise, there are still people who do a radical nephroureterectomy, which involves removal of kidney, ureter, perinephric fat, and regional lymph nodes. You might choose simple nephrectomy or radical nephroureterectomy. The point is that you have to ensure complete tumor removal without rupture and assess the extent of the disease. For patients with resectable tumors, preoperative biopsy or intraoperative biopsy is not performed because either would upstage the tumor. Like I said, if you're doing a biopsy and it has stage 1 or 2 tumor, you have to label it as stage 3. It is upstaging the tumor. Now, management. So, these days we don't believe in exploring the contralateral kidney because our preoperative imaging studies are so nice that if there is tumor, you'll know about it beforehand. And in fact, they're more reliable than your actual, intraoperative exploration. Now, if the initial imaging studies suggest bilateral kidney involvement, treatment approaches should facilitate renal sparing surgery. Even if it is stage 4 disease, which means there is pulmonary metastasis, resection of renal tumor has to be considered if you want optimal outcomes. Suppose it is local stages 1 or 2, it's not 3, and you have a distant metastasis, that is why it becomes stage 4. So for local stage 1 and 2, you do not require to give radiotherapy. It's not required. Now, coming to special situations, if your viva is very good, somebody, your examiner may ask you, what are the markers which suggest that the tumor has an intraureteric extension? So suppose the patient is having gross hematuria. Suppose this kidney becomes non-functional. So you never find a Wilms tumor kidney which is totally non-functional. And suppose the kidney is hydronephrotic. So, these are suggesting that there is obstruction and this is because of intraureteric extension. How do you handle that? You do a cystoscopy and you will need to see if this is coming to the bladder or not, and you'll need to do an en bloc resection preventing tumors spill into the peritoneum. Now, renal sparing surgery or nephron sparing surgery is important in certain situations. Number one, if it is a single kidney. Obviously, if it's a single kidney, you cannot remove that. Second, children who have bilateral tumors or who are predisposed to bilateral tumors. Number three, it's a horseshoe kidney, which is like a single kidney. And number four, if your child has a Danish-Drash syndrome or a Frazier syndrome, which predisposes him to renal failure. So you want to preserve as much of kidney tissue as possible. So this is a very favorite question of examiners. What are the standard indications of renal sparing surgery? There are four standard indications. Then for research purposes, a lot of people, like when the tumor weight is less than 550 grams and the child is less than 2 years of age, that is being studied. When it's a very small tumor detected by screening ultrasonography. So these are the relative indications. But a single kidney, horseshoe kidney, syndromic child, and a child who's predisposed to bilateral tumors, then you should do a renal sparing surgery. What about the involvement of adjacent organs? So see, I'm sure you must have seen a couple of Wilms tumors. You would never have found that it is involving forget the adrenal, but you would not find it is involving the colon, or it's involving the liver, or it's involving the spleen. But yes, if there is involvement of adjacent organs and you feel that while I'm doing surgery, I would need to excise them en bloc, be prepared for higher complications. So in such situation, it is suggested that go for neoadjuvant chemotherapy and secondary resection. Similarly, primary resection, primary means without neoadjuvant chemotherapy, of liver metastasis is never recommended. Now coming to lymph node sampling in Wilms tumor. So this is another crucial aspect of lymph node sampling in Wilms tumor. So we have two philosophies. Some people believe that there is a 5-station sampling. Some people believe it's a 7-station sampling. When we operate, we take lymph nodes from the hilar region, the suprahilar, infrahilar region. Then we have to take the para-aortic on the left side and the paracaval on the right side. Again, we take at 3 points. So suprahilar, hilar, infrahilar. We take the peritoneal or the mesenteric nodes, and we take the internal iliac nodes. The most important reason, like I just now mentioned, for upstaging a tumor from 1 or 2 to 3 after surgery is the presence of lymph nodes. I remember in one of the papers from NWTS, they said that if you randomly sample 7 nodes, there's a very high chance that one of them would be positive. So this is important. lymph node sampling in Wilms tumor. No surgery of Wilms tumor is complete without lymph node sampling. Now, neoadjuvant chemotherapy is given when the Wilms tumor is inoperable. Yes, you have to give. It's a solitary kidney. You want to reduce the tumor. In fact, all the indications when you need renal sparing surgery, you have to give neoadjuvant chemotherapy. So all those indications will figure out here as well. This is the same thing. Chemotherapy. Okay, two important points which generally examiners ask to confirm if you've actually given chemotherapy by yourself. So you know that chemotherapy is given by, it is calculated not as per kg body weight, but is calculated as per body surface area. But the exception is, number one, all young children, all infants younger than 12 months, they mandate a 50% reduction in chemotherapy dose. So whatever is the dose recommended, if the child is less than 12 months, you reduce the dose by 50%. Second point, for a child less than 12 months, you don't calculate the body surface area. You calculate the as per the per kg body weight. Two exceptions. When the child is less than 12 months, dose is calculated per kg body weight and it is reduced to half. Now, these are chemotherapy regimes which you have to memorize by heart. So we have EE4A, DD4A, regime I, regime M, regime UH1 and regime UH2. I've given like in EE4A it is 2-drug regime for 18 weeks, DD4A it is 3-drug regime for 24 weeks. In regime I it is 4-drug for 24 weeks. So essentially I would prefer that you have to memorize, but I will give you a trick here. If in your exam, this is not true for the written exam, but I'm talking about the verbal, your long case. Suppose you're done with the long case, if it's the history examination, you made the diagnosis, differentials, and you come, your examiner asks you, okay, so what chemotherapy would you want to give to this child? And you say, okay, sir, this child fits into this category, so I want to give a 3-drug regime, the DD4A regime. Okay, so tell me about the DD4A regime. So I would always say, sir, I want to make a point here that although I remember the names and doses of the drugs currently, but I have a philosophy that whenever I administer a child chemotherapy, I would consult a standard book. I would confirm and I would not give by memory. So once you say this, even if you spell out a little bit of error so that you have actually covered up. And the reason why you say this, that I will check it by the book, because chemotherapy can be toxic. So it's a good idea that whenever you're giving chemotherapy, don't go by what you remember. Go by what is written in the books. Radiotherapy is guided by three factors: the stage of the tumor, the histology, and the molecular signature. Three standard, the entire treatment of Wilms tumor is guided by these three factors: staging of the tumor, tumor histology or grading of the tumor, and the molecular signatures. So postoperative risk factors for worse local control if the resection is incomplete, which means the margins are positive or nodes are involved. These are indications for radiotherapy. Radiotherapy is not used in stage 1 or 2 favoral histology Wilms tumor. We remember the NWTS1 findings. Favor histology Wilms tumor stage 3. So we need to give flank or abdominal irradiation. Unfavorable histology, again, flank or irradiation in all the patients. Now, this is about the doses. I have seen that examiners, although we are not radiotherapists, but examiners want to listen this 10.8 grays in fractions. So they have this thing that although you're not going to give radiotherapy, but you should have a basic idea about the radiotherapy concept. So I have just put the most important lines here for you all. So this is the minimum that you need to remember. Radiation delayed by more than 10 days after surgery results in worse local control if it is unfavorable histology, but does not result in worse local control if it is stage 2 to 4 favorable histology tumors. Now, current COG guidelines allow for omission of whole lung irradiation when obviously there is no extrapulmonary metastasis, loss of heterozygosity at 1p and 16q, and complete response at 6 weeks, rapid response, this is what they call it, after VCR, ACD, and doxorubicin. This is pulmonary radiotherapy, the dose of 12 gray in 1.5 gray fractions in children older than 12 months and 10.5 gray in children younger than 12 months. Now, this is something which is again required. So here what I have done is I have put the slides as per the stage of Wilms tumor and divided them into categories and tried to give you a 4-year recurrence-free survival or event-free survival, and a 4-year overall survival. So in stage 1, you see that the 4-year overall survival is nearly 100%. I come to the next slide, which says about stage 2 Wilms tumor. Again, you see that the 4-year overall survival is 100% unless it is diffuse anaplasia, where it is 84%. So I would suggest that you take printouts and keep it with you. And gradually, as you use it in your clinical practice, you'll get a basic idea of how these things work. This is about stage 3. Stage 3 has a lot of components. So this is the first slide. This is the second slide. So febrile histology, all patients, you have 97% survival. Then febrile histology without loss of heterozygosity in 2 columns and with loss of heterozygosity. So survival is going down. Then you have with loss of heterozygosity and negative lymph nodes or positive lymph nodes. So the survival varies in stage 3 from 97% maximum to minimum 92%. Stage 4, it is survival is actually less, so it is 79%, 71%, even 53%. There's other conditions in stage 4 Wilms tumor when you have isolated lung nodules or you have no loss of heterozygosity or you have loss of heterozygosity. So again, lot of conditions, subconditions. So this is something which is the difficult part of Wilms tumor, but trust me, no examiner would also remember such minute things. But you have a basic or a gross idea. When I was a resident, the way I memorized was I had made a working flow diagram. So which says like starting from 1, 2, 3, 4, and then based on these 3 points, whether there is lymph node or not, whether there is 1p16q or not, I would divide them into categories. So, that gives you a mental picture and helps you memorize. I wanted to do this for you, but I could not get time this time. My dad was actually scheduled for surgery last week and something is going on. But then I still plan to make it. If I'm able to do it in the next week, I'll just share over the IAPS group. Now, coming to the umbrella protocol, something which I'm sure you must have heard. It's a favorite topic for the examiners these days. I have seen a lot of short notes coming up. I have seen examiners discussing umbrella protocol, during long cases as well. So it's a recent innovation in the field of pediatric oncology, including Wilms tumor. An adaptive comprehensive trial structure where multiple studies have been incorporated into one framework. So the basic essence is to improve the efficiency of the trial, personalize it for the patients, and of course, the benefit of long-term follow-up. So if you are to define the umbrella protocol, you can simply say it's a single master protocol which is designed to evaluate multiple targeted therapies in a single disease context based upon the molecular histological subtypes of the tumor. So in pediatric oncology as a whole, and particularly Wilms tumor, it allows for inclusion of diverse patient groups. So Wilms tumor है, clear cell sarcoma है, rhabdoid tumor है, or within Wilms tumor, those tumors that are stratified by stage, by the histology, grading, molecular markers, status of relapse, and enables precision in both therapeutic allocation and data analysis, so the research part. So basically, the umbrella protocol is trying to address the heterogeneity of Wilms tumor, which can present as different histological varieties or risk grading or outcomes. So if you remember, traditionally, Wilms tumor was covered under NWTS and SIO. Now, you see, NWTS was 1, NWTS 2, NWTS 3, 4, and 5. So if I were to use the word, I would say it is a sequential clinical trial. एक ट्रायल होता है, उसके रिजल्ट आते हैं, फिर दूसरा ट्रायल होता है, then you have the third trial, then you have the fourth trial. So it is a sequential trial design. Same thing was SIOP also. But when you talk about umbrella protocol, it's not sequential. It is taking everything, all varieties, all patients together. So it gives you the advantage of efficiency because you are testing multiple treatment arms concurrently. It gives you the the adaptability. So you can add or drop arms without designing a new study because an umbrella protocol. So in between the study, you realize something is not working or something is causing bad results, change it. drop the arm, add a new arm. Then it incorporates genetic markers to give you the benefits or advantages of precision or personalized medicine. And then it's comprehensive. So you can include patients who are coming fresh upfront. You can include patients who have coming after relapse. You can include the rare subgroups like clear cell sarcoma of the kidney, etc., etc. So what are the advantages? Advantages I have put up in the next slide. So I thought that making these slides look like this may make it easier for you to remember. So the advantages include number one, personalized medicine. So the umbrella protocol aligns the intensity of treatment with the biological aggressiveness, which is predicted by the grade of the tumor. Second, the real-time pathology and radiology review, which see, this is ideally designed for the country. I'm not talking of India, but theoretically speaking, it gives you real-time pathology and radiology review. So there's a centralized review and quality control. Third, it streamlined the enrollment. So with one entry point for all Wilms tumor patients, there is no delay in determining the eligibility of trial. Patients are automatically funneled into appropriate therapeutic studies. You can incorporate new data, new biomarkers. It facilitates your research on the rare subtypes because you don't have to design separate trials for them. And overall, the context is improving the relapse and salvage planning therapy for this. So it's basically now what is going on is the SIOP RTSG 2016 umbrella protocol. It includes Wilms tumors, it includes non-Wilms tumors like clear cell sarcoma, rhabdoid tumors. It includes relapsed Wilms tumors as well. So this is about the umbrella protocol. I'm sure with this much information, you can write a short note. You can answer the questions during your long cases and short cases. Then the next aspect is the outcomes of Wilms tumor. So children with stage 1 and 2 febrile histology, we have seen that they have more than 90% event-free survival and more than 95% overall survival. If you remember the colored slide which I had previously where we planned the treatment, I had given these two columns of event-free survival and overall survival both. These are the factors which govern the survival in Wilms tumor. So one, whether it is... Oh, something happened at my end. Are my slides visible? Can somebody confirm, please?
Yes,
Yes,
sir,
sir.
it's
They are.
visible, sir.
Okay, great. Thank you. So, what are the predictors of survival in Wilms tumor? So, number one is the histology. So, if it is a stage 1 or 2 febrile histology, your survival is better. If it's a poor prognosis like diffuse anaplasia, bilateral disease, or recurrent, then of course its a survival is less. So you have to talk about, if you are asked about survival, you talk about these four things: the febrile histology, diffuse anaplasia, bilateral disease, and recurrent disease. Where stage 1 and 2 febrile histology is a good prognostic factor, and the other three are poor prognostic factors. Then I've tried to summarize the chemotherapeutic drugs. So there are four major drugs: vincristine, actinomycin D, doxorubicin, cyclophosphamide, and their common side effects like peripheral neuropathy with vincristine, or cardiotoxicity with doxorubicin, or hemorrhagic cystitis and myelosuppression with cyclophosphamide. These are the drugs which are used in other regimes, less commonly used: ifosfamide, etoposide, carboplatin. But I'm sure this gives you a wholesome picture and easy to revise during your exams. Coming to survivorship and cure rates, that is the last part of my presentation. After this, we just have one more section on research. So with modern therapy, more than 90% of children with Wilms tumor survive long term. They enter into adulthood with a cure. However, survivorship comes with healthy challenges. So studies from COG and Childhood Cancer Survival Study have followed Wilms tumor survivors for decades. So overall, the point is that survival has, we started from 20% or less, and we are at more than 90% now. Renal function. So, if after unilateral nephrectomy, if there is no recurrence in the other kidney, generally these children do well. The other kidney does undergo compensatory hypertrophy, which is something which is discussed in the long cases. Risk factors: hypertension, proteinuria, and chronic kidney disease. What are the conditions which the risk factors are particularly important? If it is bilateral disease, if the patient is receiving nephrotoxic chemo radio, and those who already have predisposing genitourinary abnormalities like Dennis Drash or WAGR syndrome. Come what may, if you have a single kidney, then a lifelong nephrology follow-up is recommended. Cardiotoxicity, like caused by doxorubicin. So early onset heart failure is rare, but subclinical cardiac dysfunction is common. So COG recommends lifelong echo surveillance, early management of hypertension, and other cardiac risk factors. Second malignancies can happen, especially if the child has received radiation therapy or a high cumulative dose of alkylating agents or anthracyclines. If this question crops up, then trust me, you'll be asked what are the common second cancers. So breast, bone and soft tissue sarcomas, leukemia, and thyroid. The cumulative incidence at 25 years after therapy is only 1 to 2%. So it's not a real major concern, but then those examiners who know about this, they feel some pride in asking about second malignancies. Fertility and gonadal function. So treatment-related gonadal toxicity is an emerging concern, especially girls who receive pelvic irradiation or boys who have bilateral tumors or spinal irradiation. So what do you do? Effects can be delayed puberty, infertility, and menstrual irregularities. Sometimes indicated but rare in Wilms tumor is fertility preservation techniques like oocyte or sperm cryopreservation. Growth and development. So radiation exposure during childhood may impair growth of spine or irradiated limbs, especially if therapy is given at a very young age. It can also impact the production of the gonadal hormone, the density of the bones, and secretion of the growth hormones. The neurocognitive outcomes. So it may impact your attention span, executive function, and school performance. Psychosocial adjustment. So the patient may experience anxiety about relapse or health complications, poor body image, and survivor guilt or post-traumatic stress. Last is syndromic association genetic counseling. So when the child has these syndromes, they require multiple specialty care, long-term surveillance, and genetic counseling. So, these are a lot of slides now. I want to go back again and give you a mantra here which will help you. So when I am discussing this part of my lecture, I'm actually preparing you for the situation when you get an answer in your written theory about long-term outcomes of Wilms tumor. See, now if you reanalyze these slides, you will see that I have not given you loads of material to memorize or to mug up, but I have given you headings which will make your answer look very mature and which will convince your examiner that you should get 80% marks. So one slide about survivorship and cure rates in general, talk about the renal function, talk about cardiotoxicity, talk about second malignancies, talk about fertility and gonadal function, growth and development, neurocognitive and educational outcomes, psychosocial adjustment and quality of life, syndromic association, and genetic counseling. So once you've given all these headings, your answer looks very mature. And by increasing the number of headings, you are actually decreasing the amount of material to be written in each heading. Now, this is the last slide for today, where, what happens is many times you get this thing, the reset advances in Wilms tumor or a question like that. Sometimes the examiners can even ask it when in your long cases. So the current research trajectories in Wilms tumor are focusing on refining risk stratification, exploring the tumor biology, reducing the treatment burden, and developing targeted therapies. So you see the lavender box is about molecular and genetic profiling. We know that we have incorporated in treatment the loss of heterozygosity at 1p16q, gain of 1q, TP53 mutations, mutations in WT1, WT2, WTX, and CTNNB1 genes. Second, the efforts are underway to develop biomarkers which can predict the relapse in advance so that you can intensify the treatment, or which can help you know how the child would respond to therapy, or which can enable detection of recurrence. So there are three specific areas which are being worked upon. One is circulating tumor-free DNA. Now, suppose you want to see, I'll tell you the situation. You want to see the change in the behavior of tumor cells after chemotherapy. Then you need a biopsy. No. So in the blood, you can identify cell-free DNA, circulating tumor DNA, and you can study the changes in that DNA, obviating the need for biopsy. Second area is urinary biomarkers. And third area is transcriptomic signatures. Transcriptomic signatures is green. It's a green box bottom point. Transcriptomic signatures means gene expression. So when you talk about whole exome sequencing, that is the anatomy of the genetic structure. And when you talk about transcriptomics, that is the physiology. Whole exome will tell you that this mutation is present in this gene in this child. Transcriptomics will tell you, hoga mutation, this gene is not expressed, so that mutation doesn't make a difference. Or this mutation is there and this gene is overexpressed, which means that this becomes significance. So whole exome is the anatomy and transcriptomics is the physiology. Third is targeted immunotherapies. So like people are studying the IGF-2 pathway inhibitors because this pathway is overexpressed. Now through transcriptomics, we realize that all Wilms tumor patients have an overexpression of IGF-2 pathway genes. And now we are studying if we inhibit this pathway, will it lead to better outcomes of Wilms tumor? Similarly, we have the mTOR inhibitors and tyrosine kinase inhibitors. All these form part of immunotherapy. And finally, if all these things can lead to treatment de-escalation and better survival. This is possible through global collaboration and harmonization like in the umbrella protocol. And finally, all these things will, culminate into personalized medicine for the child or precision oncology. So this is all from my side for today. I have not covered a lot of aspects which form a part of standard Wilms tumor. Say I have not talked about nephrogenic rests, which is simple. You can read about it. I have not talked about the different chemotherapy regimes in a great detail. I didn't cover clear cell sarcoma or rhabdoid tumor. But I have given you enough information that you can handle the viva. And now when you go back to your books, you'll find this topic very easy to read. So thank you very much. I'm here to address any questions.
Thank you, sir. Thank you, sir, for the extensive lecture.
So imagine it was 1.5 hours. I hope that none of you was
No,
bored.
no, not at all, sir. Really, it was really useful. Cleared up a lot of things for me, sir. Sir, I'm sorry, sir. I had a few, I think, little basic questions only.
Uh-huh.
Sir, in SIOP, when we stage a tumor, do we stage the tumor as we on the initial imaging characteristics, or only after 4 to 6 weeks of chemotherapy?
So this is a pretty dynamic process, but the final staging depends only when you remove the tumor after the initial chemotherapy. So at that point, they look into the classical histology of the tumor, number one. They look into the response of the tumor cell to the chemotherapy regime, and they take into consideration the initial radiology also. So
Okay.
they
Like,
you
for example, if a
generally put,
patient,
uh-huh.
uh, it let's say the patient had a localized renal disease only, sir, involving the entire kidney, but limited within the capsule. But
Stage one.
technically, but then the CT chest shows a few suspicious nodules in both the lung fields.
So it is stage
But
4 with
after
local
chemo,
stage 1.
but after chemo, the lung mets have disappeared. Now, what stage would we take it as?
So they would take it as stage 1.
They would
So
take
that's
it
what
as
I
stage
so
1.
I made a mention somewhere in my lecture that as compared to a front nephrectomy, you may end up sliding the stage in SIOP classification.
Yes, sir. Okay. And also, sir, in PSYOP, it's not compulsory to take a biopsy then. We would only take a biopsy in atypical cases.
Uh-huh. They would start chemotherapy right away.
Okay. Okay, sir. Sir, and also that supradiaphragmatic IVC thrombus question that I had. Now, if we're able to, like with the expertise available at our center, if we're able to remove the entire thrombus during the primary surgery itself, would it that would still come under a higher stage, sir? Or
Yes.
like technically we have removed the entire thing, so shouldn't it come under stage 2?
There can always be a microscopic tumor left. I'll tell you something very interesting. It's not directly related to your question. Okay, I'll answer your question first. It counts at a higher stage, number one. So they stage it differently when it is infradiaphragmatic and supradiaphragmatic. I was not planning on disclosing this, revealing this, but then a very in the near future you'll see a novel on the stand which is about a child on Wilms tumor. So I just completed writing it a couple of days back. So it's about a child, a, a patient of mine who I met as a resident, and I had fond memories of him over the years. So I don't know how it came into my mind, but then this aspect is covered in that. So I got it about the extension and recurrence and microscopic residue. There's another question in a chat box. The radiation oncologist we refer to doesn't consider preoperative biopsy as the sole reason for upscaling to stage 3 and the need for radiotherapy. In last stage 1 to 2, what to do then? You have to reason it out with him with the standard available literature. I know that there are a lot of issues with the management of tumors because, see, at the end of the day, nobody can force me to follow NWTS. So for you as pediatric surgeons, I would, yeah, for us as pediatric surgeons, one thing is that we have to decide what we will follow. We cannot force our radiologists, radiation therapists, or pediatric oncologists to follow the same thing that we are doing. But it is generally a teamwork, and if you can create a consensus in your team, so it depends. That's the answer to
Sir,
Charu's question in the chat box.
sir, is there a concept like when we take a biopsy, if we take a core needle biopsy versus incisional biopsy, like the core needle biopsy doesn't upstage, but an open biopsy
No,
as
no,
such
we
would
consider any
we
biopsy as a
consider it. Okay, okay, sir.
See, point is at the end of the day, it's your patient and you want the best results. So
Yes, sir.
you would think like the patient's mother or father. Uh, so and then needle track recurrences have been described.
Yes, yes.
So it's
Okay,
good to upstage it.
okay, sir. Thank you, sir. So I think Alish had a question. Which book do you recommend for us to read about Wilms
Yeah, sir,
tumor?
because there are a lot of
I read
many
that
questions.
question. I was intentionally not willing to answer that question. That's a very difficult question. So I would say you can build up your basics with this thing. Kilali's King. The chapter on Wilms tumor in Kilali's King is actually wonderful, but that doesn't cover a lot of aspects. एक तो
Hmm.
this book was revised couple of years back, number one. Number two, things are changing at a very rapid rate. So yeah, so when I was a resident, we were reading Pisopoplac, especially for
Hmm.
these 3 or 4 tumors. Pisopoplac is a multiple volume book. It's very extensive. But what we were recommended by our teachers was that you get photocopy of these 4 or 5 tumors that are hepatoblastoma, neuroblastoma, Wilms tumor, and rhabdomyosarcoma and teratoma, sacrococcygeal teratoma. But I think Pisopoplac again presently is 4 or 5 years old. We don't have a recent edition in the market. So at any point of time, you have to build up your knowledge by this thing. So the material that I have given you, it's from multiple sources. So I have consulted the Quran, the green one, which is currently in vogue. I have consulted Kelalis King. I consulted the website of the National Cancer Institute. I have included things which we follow in our practice. I have tried to give you material which is totally non-controversial. I have removed all those things which are either controversial or which you don't require as residents. So you would
Hmm.
understand again, Wilms tumor. If I have to talk on a forum where all the oncologists are sitting, I can continue speaking for 5 hours. But then, you have to decide कि आपके audience के लिए what is good for your audience or what is the domain of your audience.
Hmm.
So I'm sure you can have these slides from the recording that you have.
Yes, sir.
So this will give you good information. Start by building up through Kilalis King. मतलब Kilalis King को
Okay.
base बना लो and then keep adding information.
Thank you, sir.
The Wilms tumor chapter in the upcoming IAPS book is also written by me so that you can use it as a guide.
Okay, sir.
So wish you all a good night. I'm sure after having been bored for 2 hours, you'll all have good sleep today.
Yes, sir. It was really an excellent lecture, sir.
Thank you very much. I'm glad you all loved it. I was till the time I finished the lecture, I started the attendance maximum was 25, and at my last slide was 22. So that gave me a feedback कि ठीक है लोग कुछ जम रहा है कुछ तो.
Sir, in between I think I saw 28, 29 and all. So I
हाँ.
think people were joining and leaving as they got some work.
Yeah.
So
But at the end it was see what counts is at your last slide how many people you have. There were 22 at the last slide. चलो ठीक है. It
Thank
okay,
you,
was
sir.
sir.
great. Thank you for this
Thank you
opportunity.
so much, sir.
Okay. Good
Thank you
luck.
for your
Bye.
time, sir.
You're
Thank you.
welcome. Bye bye.
Bye, sir.